Yes, yes, you have.
Is the screen visible?
Yes,
Yes.
yes.
Go ahead.
Hello, everyone. So, as introduced, I am Jatin Bhukal. I work with the state facilitation team of Pallium India. The facilitation team mainly works to integrate the palliative care into the mainstream healthcare system in various regions of our country, and we are spread across different regions of India. So today's session will be about organizing palliative care. A lot of you, will be part of some hospitals. Some of you must have your own clinics. So we'll guide you through how you can start organizing your own palliative care services, or how you can start providing palliative care in a hospital or another establishment. So we'll start with this. This is the WHO Palliative Care Advocacy Triangle. So according to WHO, to set up a successful palliative care delivery center, we need to ensure three things. These are education, drug availability, and policy. Now, what is the need for education? We need education because there is lack of awareness even among healthcare professionals. There is lack of awareness among the general public, and there is lack of awareness. Hello, am I audible?
Yes, yes, Jatin, go ahead, please go ahead.
Sorry. As there is lack of awareness among the general public, the healthcare providers, and even the administrators. So for these, we need to create awareness programs and educate the masses about palliative care. We need to ensure there is drug availability, because the mainstay drug for palliative care and pain management is morphine, and it is regulated. It has quite of regulations around it. However, the NDPS Act has been amended in 2014. Most of the states have already implemented the amended rules. Some of them are yet to, but we are also working on ensuring that there is drug availability, there is availability of morphine and other opioids in almost every region. For policy, we need to ensure that there is a policy that is drafted by the administrators, the government, so as to ease your easier work of providing these services, and they can, the framework of the policy, you can go around it, and it will help you provide services more easily. The next is, this is the Indian context of palliative care delivery. So palliative care delivery broadly classified into three major categories in India. First is the standalone hospice or PC center. A standalone hospice or PC center could be an independent facility which is solely providing palliative care services regarding pain management and symptom management. And they also provide palliative care services. The main difference between a hospice and palliative care can be that hospice is usually, hospice care is concerned when the patient is usually, during the last times of their life, whereas palliative care can be implemented and started right from the point of their diagnosis. So, and the second one is a department or unit within a hospital. We can have an established department of palliative care within any hospital. It could be a government hospital, could be a charitable or a for-profit hospital. Then the third one is community-based home care, which we believe is a very important part in providing palliative care delivery across India. So in community-based home care, we reach out to the patients. We create that social capital bridge, and we reach out to the patients and their homes to provide them with the palliative care services. And this involves the role of volunteers, social workers, nurses, and even doctors who go to home care visits. These are some of the examples of the standalone hospice. The first one is the Sipila Palliative Care Training Center. The second is Ruma Madonna Hospice, which is in Northeast. The third one is Palliative Chandigarh Hospice Center, which is in Chandigarh itself. And then there is Sri Guru Ramdas Hospice, which is a unit of government university in Amritsar. And then we have Institute of Palliative Medicine, Calicut, and Karunashraya Bangalore Hospice Trust. And then this is about within a hospital. So for within a hospital, this is, you can see how there is special establishment. It is written that it is a palliative care unit, and this could be in a government hospital or a private hospital or in any other establishments. My presentation just got started.
Hello, Dr. Jatin, are you there?
Yes, ma'am, I'm here. I think my presentation got stuck for some reason.
Yeah, that's all. It's just in that slide. Do you want Sangeet to share the
Sangeet, yes,
presentation?
Sangeet, can you please share instead?
Yeah, sure. Just a minute.
Thank you. So this is the community model that we were talking about, how community-based health palliative care is provided. This is usually of three types. Micro, Sangeet, can you please next again? Yeah. So this is of three types: micro, meso, and macro. In micro, the micro community-based palliative care can be provided, let's say, a volunteer or even by the family members of the patient. It can be provided. In meso healthcare, there can be a group of volunteers or a community that is looking after these patients. For macro, there are hospitals, big hospitals that are running home-based care. They are running their home care teams and providing these facilities to the patients at their home. So next, please. Next. So as we were talking about volunteers and community-based healthcare, this is the story of Ashla. She's a member of Pallium India right now, and this is a very inspiring story which I wish to share it with all of you. Sangeet, can you please play the second link? No, the video, the link in the video itself, the second link.
Yeah,
Ashla's
okay,
story.
just a minute. Yeah.
Yeah, thanks. Sangeet, can we move on to the next slide? For organizing palliative care services, Pallium India follows a DEF model, which is demonstration, education, and facilitation. So in the demonstration part, it is usually done by our training center, which is Trivandrum Institute of Palliative Sciences. Sangeet, can you please move on to the next slide? So yeah, the demonstration we have Trivandrum Institute of Palliative Sciences, which is our WHO collaborating center for training and policy for access to pain relief. The demonstrating tip care delivery in resource constrained settings. So TIPS is a very good example of that. At TIPS, we have inpatient care. We provide outpatient care through government hospitals. There is home care services which are running on daily basis. There are more than, I guess, 5 teams that daily go to different areas to provide home care. And it constitutes of a social worker. We have doctor, nurses, and palliative care assistants. So we also work for rehabilitation and reintegration, community participation, which includes the creation of link centers through which we get information and data about the patients, where they are and where all our teams need to focus more. We have a halfway home here that supports people with paraplegia and quadriplegia. They stay there and it's basically a home for themselves. They can do their all activities whichever way they are possible, and all the help that they require, it is provided to them. We have almost 21,291 patients and their families that are staying in Trivandrum. Community engagement through 87 volunteers and 14 link centers. Can we move on to the next slide? This is our national helpline for telehealth, which is available from Monday to Saturday, 9:30 a.m. to 4 in different languages. Next slide, please. The next part is education. So education is also provided through TRIPS training programs. And who do we train and educate? So for training, we have, for education, we have courses for doctors, which is the FCPM and the certificate course in pain and palliative medicine. For nurses, we run FCPN and again the certificate course in palliative nursing. We have courses for allied healthcare professionals such as social workers, and see community health officials. And for volunteers also, we have a volunteer training program. Then for students, we have students volunteer programs. We also have a Arohan program for palliative care beneficiaries that wish to enroll in these programs. And we also have specialist programs in different specializations of medicine. Sangeet, can you move on to the next? So now comes facilitation, which is the integration of palliative care into mainstream healthcare. So the main objectives of facilitation are, the first one would be catalyzing new palliative care centers and services that can be in a government setting and a charitable setting or a for-profit organization. For government, we are already working with the national health missions of various states. I personally am involved with working with Punjab and Himachal Pradesh. We have certain MOUs with some of the states, and we take up capacity building. We have trained their healthcare staff like doctors, nurses. We run special courses for them, and then later on we provide them with all the support that is needed to establish a palliative care center at their hospital. Then for charitable and for profit as well, we all have these programs running. The second is assisting in opioid accessibility in rural regions and medical institutes. So for assisting in opioid accessibility in all regions and medical institutes, we create awareness programs, and we also do opioid availability workshops with the drug controllers of different states, where we get them to a platform and we talk about how necessary the essential narcotic drugs are for the patients and their pain management. And we promote and encourage them to uh, say ease out the rules and provide more and more licensing and certifications to certain establishments that are trying to obtain them for keeping in morphine and other essential narcotics drugs. And then the third one would be enable palliative care learning in medical institutes. We are working with different medical institutions to integrate palliative care into the learning programs as well. Build up community engagement and volunteer mobilization. We work in different regions of India. We are a team of 7 people spread out in all different states and regions, and we build communities there. We create volunteer mobilization so as we can create a network of this, community and volunteer, so that whenever, even in the remote areas or rural areas, wherever there is a patient in need, we can provide some kind of help to them. Develop pain-free hospitals by eliminating serious health-related sufferings. Sangeet, next one, please. This is catalyzing, or you can say enhancing, an already running palliative care center. So what we can help with is planning of the center, recruitment, budgets, and IEC materials, all the documentations that you require, like assessment forms or OPRI registers, IPD registers, registers for maintaining the stocking of the narcotics. We provide education and skill building. Then again, we help with opioid access, help with implementation, quality care, its monitoring and the impact, community engagement. And the last one, reaching 10 million by 2030, is actually the goal of Pallium India. We are aiming to reach 10 million peoples by the 10 million patients by the end of 2030. And next on, Sangeet, please. So now coming to the crux of the session. This is how to organize palliative care services. We have made a 10-step approach. It's just a basic flow that we follow. It's not a concrete rule as such. It may be vary based on your settings. So the first one is arrange funds. So for arranging, like before starting to organize the whole program, we need to think of where we can arrange the funds from. If you are a part of a government hospital, so there are certain programs that are running from where you can avail these funds, like the National Program for Palliative Care (NPPC) and the Ayushman Bharat schemes. And even for arranging funds, you can always collaborate with other programs. For example, you can tie up with the National Mental Health Program, the healthcare programs for elderly, and also for NCDs. You can also sneak out some budget from them. And for private, of course, you can create the services and then charge for it. And if it is for a charitable or a non-governmental organization, then there is an actual challenge in arranging funds. But for them, we can always go for corporate social responsibility fundings or public donations. So whenever you will be starting your own setup, this will give you a broad idea about where to arrange the funds from depending on your setting. Then recruiting and training a team. So this is another important aspect of setting up a palliative care service, and that is having a trained team. Initially, you will have to have a doctor, a nurse, and a social officer trained in this palliative care. And going forward, as you grow, you may be required to train and recruit more allied medical professionals like pharmacists, physiotherapists, occupational therapists, dietitians, etc. But as a basic unit, we would need a doctor, a nurse, and a social officer who should be trained in palliative care and providing palliative care. Then comes building an infrastructure. So for infrastructure, it can be a room for the outpatient or a space and furniture for inpatient unit. In case of home care, you will be requiring a vehicle which can be used by the team to travel to the needy with all the essentials like medicines and other consumables. Now the next step would be procure opioids. So as I mentioned earlier as well, we need to ensure availability of essential narcotic drugs for pain relief. Now to procure, store, and dispense these opioids, you need to be a part of a recognized medical institution. However, all government facilities are already recognized medical institutions. They do not need to require a separate certificate for that. They can start dispensing and stocking opioids. But for a private or a not-for-profit organization, you'll need certain certifications, which is like the recognized medical institution to stock and dispense this essential narcotic drugs. And network building, and the next step would be network building and establish connects. So you need to establish connects with existing experts in palliative care in your region. This will help you in reaching out to more patients. And the next step then would be create awareness. So for creating awareness, this is very much important. We can create awareness for the healthcare professionals, the administrators as well, and as well as the general public, so that once the general public is also aware of what is palliative care and where the services are being provided, they will come to your center and they will avail these services from you. So the next step would be developing an outpatient department. So for developing an OP, you will require a small space where you can, you'll have a chair where you can examine the patients, and you can also have a nurse and a social worker there if needed. And you do not require much of the furniture and spacing to start, just to start a outpatient department. But the next step, which is developing an inpatient department for inpatient facility, that will involve a little more infrastructure in terms of like beds for patients, side lockers, and oxygen cylinders and other medical necessities. So this will be required for developing an inpatient department. For home care, now the next step, that is developing the home care services. For home care, you can start with one vehicle which can accommodate the team of a doctor, nurse, and a social officer. And of course, they can carry the medicine and all the consumables, and they can go to the needy, their place, and provide the palliative care services. There are certain scenarios where just a doctor or a nurse go on a two-wheeler for home care visits also, but it is about the passion that drives to start such initiatives. Then the next step would be involve volunteers. So I've already talked about why involving volunteers is so necessary. By involving volunteers, we can reach out to the needies in their places as well, and we can create a network so as to better guide the patients about where to seek the palliative care services from. Anything on the next slide. So now, of course, there are certain challenges. Now, of course, there are certain challenges in all sectors. So, like the availability of funds and human resources. Want to play safe. So, like this is, like for procurement of opioids, there are certain regulations. The drug controllers of certain states ask for more than required documents from the doctor. So the doctor sometimes do not want to go to the all this legal hassle. So they do not file for an RMI for procuring opioids. Then the next one is inadequate knowledge related to palliative care and amendments in the relevant laws. Limited human resources in palliative care. The next one, it is very important. It is not a very lucrative business. So even I have observed in some areas that because it is not a very lucrative business, it is not generating money to the big hospitals. Sometimes they end up closing the palliative care units. Now, again, the last one is mindset, a lost cause. That there is no treatment of saving a life. They are not concerned about it. Then there are challenges in the government, like different kind of challenges. For example, there is limited budget for palliative care in flexi pool. Medical colleges are dependent on the state budget. Palliative care is not a priority among all programs. Reluctance in collaborating with an NGO. We personally have experienced that with working with different state governments. They are always reluctant to working or collaborating with an NGO. And of course, getting an appointment with them, either virtual or one-on-one, endless follow-ups are there when you start to work with them, and there are a lot of follow-ups that you need to do. And of course, there are there are internal conflicts in interdepartmental or hierarchical approvals. Next one, Sandeep. This is a quality audit, standard audit tool that is used for palliative care delivery centers or programs. This we can help you with this say audit tool, and by this tool we can measure and the impact also, and how good the quality of the services that are being provided. And because of filling off this audit tool, we can find out the gaps and where we need to work on more. So this is just to show you what is the standard audit tool. The next slide, Sangeet. So this is NPPC, which is the National Program for Palliative Care. It is for integration of palliative care with existing healthcare services. So there are 4 components to it. One is curative or therapeutic oncology, acute care or emergency medicines, country's healthcare system, we want to integrate it into it, and home-based primary care or family medicine. For this, we have interdisciplinary approach in which there are doctors involved, nurses, psychiatrists, and psychologists can be involved. We have physiotherapists, which are also there through the national program for NP-CDCS, which is now converted into NP-NCD. So, and also non-medical clinicians, like medical social workers, counselors, psychologists, and allied health workers. But this is more for the people that are working in the government setting or are part of the national health missions. So, can we move on to the next slide? So this is again the government operational guidelines and overall strategy for in the national program for palliative care. It goes for the service provision, that from where all the service will be provided, capacity building, who all will be trained, community engagement. So like you can see in the service provision, there are primary healthcare centers, community health centers, health and wellness centers, and tertiary medical colleges and CCs. Capacity buildings, they are training ASHAs, ANMs, CHOs, multi-purpose workers, and of course medical officers and officials. The community engagement, for this there are sensitization and awareness of community. A lot of sessions are happening here and there in different parts of the country. There is creation of IEC material for palliative care, intersectorial linkages, and involvement of volunteers. The government is also now started to focusing on the involvement of volunteers in this program, and monitoring and supervision, reports and formats, and there is audit visits by the state program officer of the NPPC. Continuum of care, which we have comprehensive primary healthcare package at the community healthcare center or the primary health center and the health wellness center level. And they have interdepartmental references, patient referral, consultation, treatment, and linkages among the different levels of healthcare provided. And then the approach is to improve the quality of life, total serious health related relief for all, serious health related suffering relief for all patients, and affordable treatment and rehabilitation. Next slide, please. So this is where we work with the government, the National Health Mission. So we are doing, training and facilitation of different things with the National Health Mission under their NPPC program. So we have worked with 21 states and 3 UTs. Exceptions, as you can see, Bihar, Gujarat, Telangana, Karnataka, and Odisha. We are still, making moves to collaborate with them. But you can see the green regions. These are the regions where we have already started working with the government, and some, for example, Himachal Pradesh, we have already signed an MOU with them. And again, we are working closely with the Haryana government for capacity building. We are training their doctors, nurses, and the community health officers as well. And this is also again for other states as well. Next slide, please. This is work with the government for the Food and Drug Administration Department that is generally associated with, availability of opioids, procurement of opioids. So we work with the state drug controllers. We create opioid availability workshops with them. And we can see we have already conducted 20 opioid availability workshops in 24 states with the drug controller of each respective state with them. However, we are still not able to reach out to 5 states and UTs, which are Karnataka, Telangana, Tripura, and must be a couple of UTs here and there. Sangeet, can we move on to the next slide? Work with government policies. So policy framing, as initially we were talking about the WHO. The third component was policy. So why policy is so important? And we are also working with different governments in drafting for palliative care policy. But a lot of work still needs to be done on this chapter. And however, we have already successfully, created created policies for 9 states, which are, you can see the green ones, and the yellow ones are the in which we have submitted drafts. The red ones, which we are yet to touch, and hopefully will, soon we can see this entire map green. Move on to the next slide. So as I was talking about that, I am a part of the facilitation team. This is our team that work in all different regions of India. So, of course, you all will be from different regions. So if anybody of you needs any help, we have our facilitators all working in different regions of India. And I myself, I look after Haryana, Punjab, Himachal, and Chandigarh. So, next slide, please. So that was all from my side. And thank you so much. And if you have any queries, you can put it in the chat box, or you can also unmute yourself and speak. With me, I have our national lead Shalini as well, who will be able to, if I'm not able to, she'll be able to guide me better and answer those queries. Thank you.
Thank you very much, Jatin. There are a couple of questions. Before that, I just thought few more things to add on, and then we will. First, thank you very much for taking us through, and you've given them a full picture of what's happening all over India. It's just not one place, because in this platform itself, we have doctors from different states and things. Just a couple of things which I wanted to add on was, first thing is, Pallium India as such does and continues to do hand-holding. Like, see, even if they help all through the process, like in the aspect of education, then training, then setting up also, they have protocols and guidelines of how to set up, and from small level, always start in small capacity and then build up. That will be safe and sound and good from all perspective. And as you go on also, Pallium will keep on hand-holding, because we have helped, as Jatin mentioned, we have regional facilitators. See, some of them they will share this presentation for you, because I think in the penultimate slide or something, you should have seen all the all over India, there are 6 or 7 facilitators available, and they cover each region. For example, Dr. Jatin is covering 5 states. So like that, we have people, and then you easy approach, and then they will help you in all aspects. That was one thing. And then Next is regarding training. I just wanted to add on few more things. This online course what you are all attending is one option. There is also an on-site 6 weeks program. If someone has the time and interest and inclination, you can go and do that 6-week program also. Again, details can be obtained from Pallium, in which all in one, like you will have theory, skill, you will see home services, you will be part of the home care team. So that is one thing. And then the volunteer program again is something which is not only for doctors, anyone can be part of the team. The only thing required is the interest, inclination, and willingness to work. Because that's a 5-day program, Monday to Friday, an hour and a half. And that covers like a nutshell what is that they need to know. Like we do have sessions on introduction to palliative care, introduction to pain, how to set up service, how a volunteer can help. Little bit of communication also there. So that is again a program which will be very helpful. So those are the things which, and this telehealth service. So these are things why I wanted to add on again was all this, all of you can start using from now itself. The telehealth service is a 9 to 5 type of service. In that period, they will directly answer, take calls. There's a doctor also there with the team, and we do video calls and see and give advice to patients all over India. Okay, and if it is out of that 9 to 5 time, what happens? It goes to a voice message, and then as soon, that's why the service starts at 9:30. 9 o'clock, the nurse will come in, check all whatever the messages have been there in the previous 16 hours, 18 hours. And then that will be prioritized. And then they will be contacted. And then if need be, a consultation will be set up. Consultation, drug delivery, everything is done in that also. Okay. And about opioids and things in detail, we will have a session on opioid availability also. So regarding setup and things, plenty of help and support is available. Okay, now we'll go on to the questions in the chat box, Jatin, before we go on to, we'll give time for them to ask also. Just we'll clear the questions. What about sustainability? Dr. Jyoti, can you sustainability or do you want to answer straight away, Jatin? I'll leave it to you, Jatin or Shalini, whoever wants to go.
Yeah, ma'am. Our Shalini has joined with me for the questions. Welcome, ma'am, and over to you.
Good evening, everyone. Hello, Dr. Radha, and some of the very familiar names I see in the group, Dr. P.F. Couture, Dr. Pushpa Couture, and Dr. Harsharan Kaur. Thank you for joining in. Jatin, you have beautifully explained what all the facilitation team is doing. So now just catching on to the question, I think the first question, as Dr. Radha mentioned about sustainability. We would want to have little more details on that. Sustainability where? Is it in a government setup? Is it in a non-government setup? Or you want to run your own clinic? So if you can just elaborate a bit on that.
Non-government setup basically for an NGO purpose.
Okay. So sustainability would completely depend on your funding situation. You know, if it is a non-government setup, are you having a private organization? How are you planning to set up the palliative care service? Will it be chargeable or are you planning to set up on a charitable basis? If it is a charitable basis, then you'll have to depend on your donations. And there has to be a complete system where you'll have to probably pitch in for CSR funding or the micro donors or some way of collecting donations that you will have to take up. So that will sustain you in terms of funding. Regarding capacity building and the technical knowledge partnership, of course, Pallium India can help you on that and help you carry on through different steps. Like initially, you might start with a small team of a doctor, nurse, social worker. Now you want to expand then to a physiotherapist, as Dr. Jatin also mentioned, or you want to expand to larger areas. We can pitch in every time you are going to a different phase. So as a knowledge partner, India can help you sustain. But as for funding and budgeting and expanding yourself infrastructure-wise, I think you would require a source of income for yourself.
Are there any options available for foreign funding sources?
Yes, if you have FCRA, like as an organization or as a charitable, sorry?
Just continue, please, sorry.
Yeah. So if you have FCRA particular accounts to receive foreign donations, then you can have foreign donations received also. But again, that you need to have some connections in different countries who will be sending you donations. Otherwise, your micro donations can be received only through India accounts. So that is possible. Does that answer your question?
Have we answered all your queries, Dr. Jyoti? See,
Yes,
like all may not see. It's not possible to answer everything. Okay, don't worry about it. At least you've got your heads up on what it is, and then we will connect you to where you are based on your location to your regional facilitator, and then you can have more meetings and things, and then either they will solve or they will get in touch back to Pallium, and as a team, no, all of us work together. So that can be done. So if I've given at least some heads up for you, well and good. The next thing, can we start off the OP service with nurses only until there is availability of the medical officers specifically for palliative care? That one I'll answer, then the rest can take over. See, it's not that it always, no, you have to take care of your team. See, if the nurse is going to be doing everything, there is no doctor to whom she can fall back. That may not be good aspect. From you should not cause burnout for that nurse, and then in no time she will leave and go. So you should have someone who will continue with you. So if you can have a doctor as the responsible person, and then the nurse can work along with the doctor, because she may face some situations which she may not be able to. Not that I am not telling that the nurse has not got the capacity, but something may be beyond. So always you have to look ahead. So that is why we say minimum is doctor, nurse, and a social worker, so that you run a team comfortably and you also don't get burnt out. Okay. And one option is, if you have a nurse who is interested in doing, she could attach herself to a family physician or someone. As we say, no, we have this palliative care. By now you would have all known the definition: any serious health related suffering. So that would have given you or opened your eyes on what all or where all it can be provided. So from that point of view, the nurse can. And if you have a doctor who will back up the nurse in all situations, then you start. If you want to start just a home care service, you start with that, and think of having a because in some places in different parts of India, there are some family physicians who are already doing that. But they will have a nurse well trained with them and who has worked with them for long. So that is how it is. And Dr. Aiden, have I answered your query? And where from are you, if you could tell me?
Good evening, ma'am.
Am
I audible?
Yes.
Yes, ma'am. Yeah, I'm from Sikkim. So actually, I'm in a district hospital right now, posted here. So the problem with my district hospital is we have only 3 medical officers overall. So we do not have anyone whom we can post in a palliative care department. So I was thinking, like, the administration have posted 2 nurses for palliative care OPD. So I mean, we can start, like they have said that you can start your OPD with 2 nurses for now. So they are also undergoing this training, like nurses training right now. So I was thinking, if we can at least start off because unless and until we don't start, there won't be anyone won't be, they won't be seeing the requirement of medical officer there. So if we start off, we will also realize the challenges we are facing, and the admin people also, the higher authority people also will know that there is need of doctor or something like that. Because otherwise, if we don't start now, this training will go on waste, I think, because we haven't started. As Dr. Jatin, he is mentioned in his presentations also that Sikkim, it hasn't been started palliative care now. So we would like to start. So that's my dilemma, ma'am.
Dr.
No,
Radha,
see,
if I
you are
can,
trained.
Dr. Radha,
One
if I
second, you take over. You are trained, Dr. Adan, because you are getting trained now. You can be the person who can help those nurses. So,
Ma'am, the problem, the
only
problem
thing it
is
will be
I am also
extra
looking,
work for you.
I'm not specifically for the palliative care. I'm also looking after RCH program. So for me, it'll be like I can always help the nurses, but then sitting in the OPD and seeing patients won't be. I think it'll be a little tricky for me.
So that's what. See, these are all individual challenges which you will be facing in your area. So that has to be dealt, and then you have to see. You have to, like, even 1 month or 2 months you show and you give them the caseload, and then you take it from there. Over to you, Shalini.
Thank you, ma'am. Dr. Eden, if I can ask, which district hospital are you working? Is it north or
It's
south?
in west. No, west.
West Sikkim. Okay. Okay. So, Dr. Bhutia, what we have seen is in most of the government services, there is no dedicated doctor to run palliative care. Most of the government services, they don't have dedicated teams. They generally train nurses and then assign one of the doctors who's already an HOD or handling another department to handle palliative care as an additional responsibility. So that's how probably you are getting trained, and the other two doctors who must be there. So to answer your question, I think it will be encouraging, especially in a government setup. Of course, in ideal situation, as Dr. Radha has suggested, a doctor, nurse, and a social worker would ideally be the team to take care of the patients completely. But because it's a government setup, you can begin the nurses identifying the patients within the hospital or outside the hospital or within different departments. And wherever they feel that they are palliative care patients, they can refer it to you, who is already palliative care trained, and then probably you can make visits, inpatient visits or OPD visits. We generally encourage, because it's an additional responsibility to an existing doctor, we just request them to start once a day OPD, once a week OPD to begin with, or at least couple of hours once a week you are spending there. And as the numbers would increase, you will see that they themselves would ensure that all the doctors are getting trained in palliative care. But I'm seriously telling you, waiting for one medical officer to take care of palliative care, that's a very ideal situation in a government setup. It'll take a long, long time. So we would really request not to postpone it, but begin with nurses and provide the support to nurses as a doctor from your end and the other medical officers' end.
Just thank you, Shalini. One suggestion. See, as Shalini already suggested, you give one afternoon for the nurses to see the patient. Okay. What you can do is the nurses can see, and then you spend just half an hour in that half a day. You just go at the end of that for example, I'm just giving an example. If it is 1 to 4, okay, in that 1 to 4 period, 3:30 to 4 alone, you go and make sure that whatever doubt that nurse has, I know you will be having, I have also worked in government. Government work is challenging. 10 jobs to be done by one person. Okay, so what you can do is just that half an hour you can go. This is in that 2 things are solved. You're giving support to that nurse who is already willing to work. Okay, and best care for the patient is any difficult patient alone she will keep. You go see that in that half an hour. So you do that for 8 weeks or 6 weeks, 8 weeks, depending on what, and show the capacity or load to your management or to your thing. And if they want to move forward, They will help you. But as Shalini said, if you're going to wait, that the start itself will not happen and the service will not come. So it will be a bit of hard work. If you're willing to do it for short time and show, and then you make a call and then tell them this much is the load, whether you can do or not. Then they may look at the option of putting another person or something like that. Is that okay?
Okay, thank you, ma'am. Thank you so much.
Dr.
No
Bhukal, I
worries.
would suggest you to get in touch with Dr. Sangeeta Shubha. She's in Namchi District Hospital. She's also an anesthesiologist running a palliative care center. Not sure if you have already contacted her. She's been doing palliative care in her capacity since long. I think we can connect you with her, so you both can talk more. She's within Sikkim doing palliative care since long. I would request Dr. Jatin, if you can share the numbers of each regional facilitator in the chat group. So
Exactly. Thank you,
they can contact
Shalini.
Ron
Yes,
also.
I'll do that.
Because in that slide, Jatin, I saw in that slide everything, but it will be better if you could just share the all the regional facilitators in one message, so that it will be good for them. And or Sangeet can also share that in the
Yes, ma'am,
WhatsApp
sure.
group.
Yeah, I'll show.
One of you do that, okay? And next, no, there are 2 questions on morphine. I think no, those ones I will wait for opioid availability session, because in which you're going all your queries now, who can have, who cannot have, how should, everything is going to be dealt with in great detail in that opioid availability session. Don't think I am postponing or avoiding your question.
Dr. Radha, probably we can just answer the questions that are there. It's a small answer.
Okay.
Then we can, in detail,
ahead.
they'll have the opioid. Can you just go up?
Can morphine be stocked by a running pharmacy and palliative caregiver?
Simply prescribe those drugs. Yes, Dr. Couture, a pharmacy will have different rules to stock it. So there is a different legal route that they have to go for. And ideally, we want that where the doctor is, the morphine should also be there only. Opioids should, so the patient doesn't have to go to a different place. But to begin with, if it is a smaller setup, you don't want to take the responsibility right now, you don't have enough team to ensure documentation and all, then you can prescribe and then they can go to a pharmacy where it is available and they can get it. That is possible, sir.
Okay.
And who can stock and prescribe opioids in palliative care? Should we have done certification?
Correct. Yes.
You should have.
You have to do one minimum of, we always recommend 10 days of foundation training, the one that you are doing. Even the online training in Kerala, online training is also considered to be making you eligible for RMI certificate. Registered Medical Institute certificate is something that you need to procure opioids. I think in the opioid availability session that will be discussed more in detail. But yes, if you have a CCPM and all, then that is sufficient enough to apply for RMI.
Any one of them, not needed to have all the courses.
Yes,
okay.
Yes, right.
And clinical pharmacologist be head of procuring opioids?
Sorry, is that a question, Dr. Radha? Can you just...
That's what. Can clinical pharmacologist be head of procuring opioids?
No, actually, you will have to have a doctor in charge to be head of accountability of opioids. The clinical pharmacologist might be able to maintain the records for you, but ultimate accountability will be yours. A pharmacist can keep records, keep documentation, ensure there is the movement of the opioids. But ultimately, that doctor who's palliative care trained will be required to sign the registers, the forms, and he will be accountable for it.
Okay, and
I
then
think
another
a
question.
clinical pharmacologist is a doctor. I think a clinical pharmacologist is essentially a doctor.
So in that case,
they have a doctorate degree.
Oh.
Not doctorate, I'm talking doctor. He's having a MD pharmacology.
See, that is, it's variable. No, I'm not sure. That is why I'm
So in
a bit
that case,
cautious.
sir, in that case, if he's palliative care trained, then he can be. So basically, they are looking for MBBS and BDS doctors, and of course, he's MD pharmacology. He's already done his MBBS. Then he can procure. He can also be the responsible in charge in the RMI. Then sorry, I didn't know that clinical pharmacologists are also doctors.
That's what Shalini. It could be because Dr. Sri Sudha, see, it depends. If it is an MD pharmacology, then there'll be someone who has done MBBS. So that's why I was about to ask Dr. Sri Sudha, why did she put that question? Is the clinical pharmacologist not a doctor?
Okay. Hello. Good afternoon, ma'am. Actually, in our AIDS Institute only, I'm gone through this issue. So, in procuring this opiates and all, who can be heads like that? I just got it out because here palliative medicine, some fellowship courses who has done, those are looking after this. But whether MD pharmacologist can be in charge of that, like that, I got doubt.
No, if they are a doctor, so basically,
these are all doctors only, ma'am.
Doctor, they could be MD pharmacology, but they should have a palliative care training. Okay, some certification or evidence to show that they are trained in palliative care. Because using morphine from this point of view, has to be understood. That is why anyone basically, as Shalini mentioned, should have a base medical or dental degree and can have any other post graduation, but everyone should have a training, some form of training certification in palliative care.
Okay. What if then general anesthetist, madam? If anesthetic can be.
Yes, they should have training in palliative care. Any doctor, any specialty, they can. So they qualify first tick for the base qualification. Second tick is for the palliative care training.
Okay. That's what
That's all. Just I have everything. No, have a simple, clear framework.
Okay.
So one MBBS or BDS, that is one tick. Second tick is, are you trained in palliative care? So in that, the doctor element is also covered, training in palliative care. So see, not only knowing the everything about morphine, how is it used here? What is the plus and minus of it? Then comes talking everything, that will also be covered. Okay, before going further down, there was another question. How about starting a palliative care department in a for-profit hospital?
A very, very profound question, I must say, because that is one thing that we all are trying to do, encourage corporate hospital, for-profit hospitals to take up palliative care. Because generally palliative care is taken up as a charitable institute or people getting free services. But actually palliative care settings have to come into corporate world also. One of the ways to bring it up is in your ICU departments. Palliative care first thing can go into your ICUs and tell those futile treatments or the futile days that the people are spending in ICUs, to let them come out, counsel the patient's families to allow them to come out of the ICU. One of the ways that you can convince a corporate hospital is by showing them the profit. Corporate hospital will definitely talk about the profit. And for showing the profit, COVID somehow has done a lot of good to us. COVID has introduced home care. And that is what you have. Most of the corporate hospital are starting palliative care like that. They are offering home care services, and that home care services can be attached to palliative care. Of course, you can pitch into them that palliative care, you begin as home care, where you are sending a doctor, nurse, and a social worker at home to follow up on your existing patients. That will give them additional revenue. And once they will see the benefit of it, they can start involving that palliative care team for their internal patients also who are admitted, or slowly they can start the OPD as well. But major challenges, they would not want to really cancel out their patients from where they can earn more, and just for the sake of offering them no treatment or sending them home. It'll be a difficult challenge, but to make it short, the answer to your question is yes. You can start. It'll be a little strong journey and strong convincing statements that would be required to convince your management. But we can help you on that also. We have our facilitators who can join you for those meetings, go and talk to the management and tell them the profit side of palliative care also. There are a lot of profitable models working in Mumbai. Hinduja Hospital has a palliative care department. Manipal has a palliative care department. We in Bangalore, most of the hospitals have palliative care departments, and these days we have MD palliative care medicine also, palliative medicine also, who are actually heading those departments. So slowly more MDs are coming. So it is definitely, the answer is a big yes. Dr.
Yes, Shalini, I also want on, because there are, as Shalini mentioned in our previous sessions, not we've had, like when private setup want to start, first thing how you go about is you can tell them about this home service, and then you can tell them about educating. Like they can form a small team as we suggested. They can select 2 or 3 people, train them, then go about in a proper way. If they are interested, you can start either from home service, or if they're really interested in starting a pain and palliative care service and someone in their organization is willing to do that, they can get trained and get started and start off as like one session and then see their workload and then keep on moving forward and expanding the team. So we, as Shalini said, we are all working very hard to start it as a for profit, because what, this is also another branch. It's another branch or a subspecialty. Okay, when so many specialties are developing, it is worthwhile to develop this specialty also, and there is enough demand. So then we have to meet with the supply. So only thing, awareness, awareness, awareness. Many don't know, and this awareness barriers are there in professional in all levels. So we have to break barriers and then move forward. A big steep climb we all have. That is it. Okay, and then Dr. Premat Kotur has got some queries. Maybe Sangeet, that slide which had that 10 steps, no? If you could just share that. So can we start PC services in a place where it is needed from step 9 and later on to step 7?
Take that? Can I take that?
Yes, yes. You are only going to take that.
Dr. Kutur, you can start a palliative care service from any step. Well, that is a 10-step approach. You can start from any step. You have a doctor, you start. You have an OP, you start. You have an IP, you start. You have a network of volunteers, you can start. So I think that was just for the sake of just giving a direction. We had put it together, those 10 steps. But palliative care can begin just with one thought. One of the stories that Dr. Raj also shares is, about a volunteer who thought that the patient in his area is not able to go to a hospital to get what he wants. So he ensured that there is a doctor. He somehow managed a transport for that doctor to reach the patient in his house. And that's how the community palliative care started in Calicut. So I think that is exactly what, sir, you also know you have started in different ways. It can begin from any step. And I just wanted to add here from our last question we were answering, I just want to call out that it's not there that private hospitals will always be looking for profit. We have examples here. Dr. Kutur is from a private hospital only, but there are very inspirational personalities and motivated personalities who would want to do palliative care for the benefit of humanity also. So if in any corporate hospital or in any private organization, you have someone who really feels for the patient and doesn't want to just earn money, you can reach out to them, and they are those people to, support you in building palliative care in private hospitals also. So it is not just going to build the department, but it will also build the brand of that private hospital. It's a very long-term vision which that person can see. And I think I would call out Dr. Kotur for that. He's been the Dean of AVMC Medical College in Pondicherry, and he has been our biggest support to start the palliative care unit there. So just wanted to call that out. Thank you, Dr. Radha.
Yes, no, yes, dear. That's what it is. I was about to say, it's just as I said, no, it's the willingness. That's what, where there's a will, there's a way. If you want to start and do something, you will find. So, and then things will fall in its place. Initially, you may need a bit, like as I said, little bit more push and finding the right time, right place, and things. Because by now you would have seen any system, like as all physicians, no, cardiovascular, respiratory, every system has got patients. Why not? So you are, it's like a demand from all directions, and then you can provide. Only thing, in short time you will know how many you will have to deal with. Your case inflow will increase. That's why we say just start off as OP, outpatients, for few days, and then the outpatient strength itself will increase. So for
Shall I
example,
say a few
like
words, Dr.
yes,
Radha?
please go ahead.
Yeah, in fact, Mrs. Shalini already knows the model on which I have been harping for a pretty long time. And see, one good thing is, myself and my wife, we both are doctors. Okay, we come from a place where palliative care service is very much needed. Dr. Sangeet showed, Karnataka is totally red, all the places. So in such a place where we doctors are there, and please don't misunderstand me, to start with, you don't have any hassles of stocking, this drug license, those kind of things, I'm not mentally prepared, because now I consider myself and my wife is too, and we start offering home care services. And out of our, I'm not a millionaire, but certainly I have something. Keep every month I can afford to spend, say, 20,000, 30,000, 50,000, like that. That much money will be the seed money for every month to conduct the activities. And to start with, don't require anything. When go and to the places where the services are needed at their place, home. And what I intend to do is, we don't want to carry even anything with us also. Suppose some things are needed, we'll prescribe to them. Suppose a dressing is needed, everything is available, disposable things. So let them get it. With that intention only, I put that first question also. I'll convince a pharmacist to stock the drugs. Certainly they will oblige. And I will just, and this is the first phase. And in 6-8 months, if I have on roll about 50, 100 patients, then I will also assess myself how I'm liking, how we are liking, we'd go ahead. Then step 2 and 3 are quite easy, because I've got a full running hospital which I give for a lease, which I'll getting back in a year or so. This is what the model I've conceived, and certainly I don't see anything that can go wrong. And I will assess myself also, we should do what we are doing is good. And after some, because all these days I was a full-time administrator or anesthesiologist, and full-time doing this. And a part, my opinion is, in a day, about 3-4 services, 3-4 hours, certainly anybody can spare for the society. And our initial model is not to charge anything. Go to their home, offer the services, our expertise, our knowledge, our counseling, advice, free of cost. We'll spend our money, go to their place, and then come back. And if anybody wants to give money or something, I'll just simply siphon it to a patient. There are more number of poor patients who cannot afford anything. That can be given. Because when I started doing the market survey and all this NGO, these kind of things, I thought whether that all hassle, do I need to enter into that? Let us see, make this model. What, Mrs. Shalini, am I right?
That's correct, sir. Thank you so much for sharing your thoughts. I think a lot of others will get inspired to start off. That actually reminds me of another doctor who was a government doctor in Gujarat. After getting trained, he went on his motorcycle with the medicines from his own government hospital whatever he could manage, and started visiting the patients in their houses. So I think that's exactly the model that you're talking about. Within your capacity, you can start going there to begin with. And slowly as you grow, you can see how you can include, probably you would want to procure medicine yourself, or hire a nurse, or hire a bigger team slowly. So we can make baby steps and begin from any point. That's what the wanted to convey. Thank you, sir. Thank you so much for sharing.
Dr.
your thoughts.
Kotur, just for information, so are you planning to do this in Karnataka or in Pondicherry?
Yes, in Karnataka.
Okay, yes, because where there is a need, that's what I was thinking.
Yeah.
Because if as we all saw today, no, wherever there is a need, yeah, if it goes there, really, everyone, many such people have done. You only always again baby steps. Don't take big steps and make life difficult for anyone. When someone is willing to do something, don't do it slow and steady and see whether it suits or works, and then make a call. If it suits, well and good. If it doesn't suit, also well and good. Because that will be a better approach. And from that point of view, our regional facilitators will be able to help you in, like, for example, in procuring or getting contact with local people, because we have our regional facilitators covering few states, so they may have more contacts, and that help can also be provided. Anything else in the chat box? Just let me check. I think we have anybody else wants to ask anything now? See, because we were just going through the questions in the chat box. Now anybody else wants to unmute and ask, and what is that in the whole session today, what was that helpful, or anything you have query in training, demonstration, facilitation, anything, please unmute and ask. Thank you, Sangeet. You've put all the now in the chat box. You've got all the contact, so that you will know for the region, and you could share the same message on the WhatsApp group also, Sangeet, because that will also be better, so that everyone has it, and then it's their wish, because people are from different regions, no? So whatever is their region and contact. And one more thing, I have been telling this, I would like that also to be shared, Sangeet, is that what are the regional hospitals where they could go for their hands-on. I remember there are about 40 to 50 hospitals all over India, where any of them, they can go for 5 days or 10 days hands-on to their nearby places. So that one also please find and share, Sangeet.
Okay.
Because see, anyone who wants to go for a hands-on for 5 days or 10 days, I would say first option is coming to Pallium, because in one place you will see everything. So option one, no, it's too far. Then also I say do something which is in the Pallium list. At least there are many places, like as we have been telling today, there are so many private Tata centers, Cipla centers, so many centers are there. They are also there all over India. Some are oncology only, some non-oncology and oncology. So different types are there. So at least do some 5 or 10 days hands-on as soon as you're doing this program, because all fresh knowledge in your head, then utilize with the clinical and skill also. So that will be helpful. Some observership for 5 days or 10 days will be very helpful, so that whoever wants to start off will give you so much confidence with confidence go in, and then anytime you can all get in touch with Pallium for advice and things. And you can very well use the telehealth services where also help is there for you anytime.
Madam Radha,
Yes.
we have already identified one trained nurse, retired nurse, who has shown inclination to join her. And I learned that some organization or hospital in Pune is, nearer to my place, he offers free training for nurses. Is it something like that? Because I got the information, I don't know if you can remember.
Sir, so that can be the
Go ahead,
Supla Pune Center. They might be offering free training. Do you, by any chance, by any chance, do you have the name of that center with you? Because actually, Pallium India has identified, they have come up with an agreement with certain centers which are called hands-on training partners. Like after our online course, all the doctors and nurses, they feel that they would require a hands-on training also. And come, as Dr. Radha mentioned, coming to Pallium, which is, of course, we always encourage everyone, would not be possible. So you can go locally and do that training. So as Dr. Couture is also saying, lot of centers are offering free trainings as well. Like to give you an example, in Telangana, MNJ Cancer Institute, Hyderabad offers a lot of trainings. So far we have heard they are free. In Karnataka, we have Karuna Shray in Bangalore, which offer a lot of trainings. And many a times these trainings are free. And sometimes there is a very nominal fees which anybody will be able to pay. So we have a whole list of centers which training team, I think at the end of the session, they do share with everybody, which are affiliated partners of Pallium India. So sir, the one you are saying might be our hands-on training partner only offering free training to nurses. It can be Supla Training Center in Pune.
And double check. Like get in touch, Dr. Kotu, get in touch with Sangeet so that he can get in touch with the team, and he will give you the contact for Cipla Center in Pune, and then you contact them personally. If you have a nurse who's interested and all, best is to train them. See, initially at least to have one nurse, then that will make. See, why am I insisting nurse, social worker and doctor? All three of you can have a comfortable, peaceful time to render the service nicely. Because stress or burnout is not a good thing. And when you're doing for the well-being and in doing everything in goodwill for the patient, why or not get burnt out? No need.
Thank you, madam.
So that's all. So no worries, get in touch with them and then appropriately contact. That's all. Regional centers, that is the question there. I think that will be, Sangeet will share that. Because I think it's a big Excel, Sangeet. I remember seeing it before. It has like 40 or 50 hospitals, which you find out and share. Okay, in that case, I think I'm going to hand it over to you, Sangeet and Shalini. A big thank you, Dr. Jatin. As always, nice to see you too.
Same here, ma'am. Thank you so much.
And thank you everyone for taking out your time. I know doctors have been so busy looking after patients, but still taking out time for extra studying and coming for these courses. That's really commendable. And thank you so much for doing it. We are there to support you, to support you with all the administrative requirements of the society. Wherever you want to build a palliative care center, the regional facilitators are always there. Please reach out to them. Or if there is anything, the training team or I am here to support you. Thank you so much for
thank you very much.
To do it. Thank you, sir.
Thank you, Dr.
Thank you, everyone.
Wonderful presentation.
Thank you,
Shalini. Thank you, madam.
Thank you.
Thank you.
Thank you all for joining and participating in the sessions actively.
Thank you, Sangeet.
Yeah. Thank you.
Thank you, ma'am.
Thank you. Let's see you in the next session. Bye.
Nice. My video is not working.
It's okay, ma'am. It's okay. Thank you, ma'am. Bye-bye.
Bye.